Our series of webcasts related to opioids and opioid epidemic. This is a collaboration of efforts between OHA's Opioid Response Initiative, our Opioid Data Collaborative, the Behavioral Health Work Group, and our OHA HIN. So we have surveyed these stakeholder groups and others among our member hospitals and are bringing to you a wide spectrum of topics that are meaningful and actionable in your daily work. One of these topics, and that which we are addressing today, is about starting an opioid stewardship program in your hospital. My name is Paul Hicks. I'm the Vice President of Clinical and Physician Affairs here at the OHA, and I'm so very pleased to moderate today's webcast. Today we are privileged to host a leader in this field, Joan Papp, an emergency medicine physician at Metro Health Medical Center and Director of the Office of Opioid Safety. Before we begin, though, let's do a little housekeeping. So first, during this presentation, all of the participants are muted. So please know that throughout this presentation, though, we encourage you to type in your questions through the chat box feature on the right side of your screen, and we will address those questions at the end of the presentation. Second, this program has been approved for 1 contact hour of continuing education. For non-nursing personnel, it may be submitted for non-category 1 credit. We will be sending all of those on the attendee list a link to the SurveyMonkey evaluation tool, and then we will send you your certificate after you complete that evaluation. And this link will remain open for 2 weeks. If you have any questions about it, please contact the good Dorothy Aldridge at dorothy.aldridge@ohiohospitals.org. So now it's my privilege to introduce our speaker and our guest, Dr. Joan Papp. Dr. Papp is a leading expert on the opioid epidemic here in Ohio. She chairs the Opioid Response Initiative for us here at the OHA and serves on numerous state, regional, and national efforts to address this crisis. She's the founding director of the Office of Opioid Safety at Metro Health and has launched Project Dawn in partnership with Governor Kasich's efforts in this area. She's an associate professor at Case Western Reserve University, having received her bachelor's in science from Cleveland State University and her doctoral degree from the Medical College of Ohio. She is both board certified and a fellow in emergency medicine and is currently an attending physician at Metro Health Medical Center. Dr. Papp, welcome.
Thank you so much for that very kind introduction, Paul. It is my honor to have the opportunity to speak to all of the OHA member hospitals and to present this information to you today and our experience here at Metro Health. I'm going to go ahead and start off by giving a little bit of background about the opioid epidemic. Do I have control of the screen here? Okay.
Yes, you should have control now.
Okay, wonderful. So we have some objectives today. First, I want all of our participants to walk away with a better understanding of the scope of the problem that we're facing in our community and in our state, and what some of the contributing factors have been that have led to the crisis that we're now confronting. I want us to be able to understand some of the initiatives and interventions, but I also want to provide a pathway to understanding what our priorities are. How do we start and where do we move forward? Next, I want you to be able to understand the evidence for the interventions that I'm going to describe. And then lastly, I want you to be able to outline a comprehensive strategy to address the opioid crisis in your healthcare system at the end of this webinar. So let's first take a walk back in time and kind of go through sort of the history of this epidemic. If we look back to the mid-1990s, we saw that this epidemic started really in 3 waves. And the first wave can be characterized by an epidemic of prescription opioids. We saw that begin in the 1990s and progress to about 2010. There was a transition about that time to the use of illegal heroin on the street as prescription opioids became less available. And that persisted until about 2015, when there was a change in the illegal drug market, and fentanyl became the predominant illegal drug that was available out on the street. And that is currently in the wave that we are facing right now. The majority of the morbidity and mortality associated with the opioid epidemic is primarily from fentanyl. So how did we get here? If you take a look back into the mid-1990s, there were a number of factors that contributed to the epidemic that we're currently in. There were changes in state and federal regulations, and what we saw as a result of that was a 643% increase in the distribution of opioid grams in our state. That's that shaded in blue part of the graph there. What we didn't anticipate with that dramatic increase in distribution of prescription opioids was what would come in the wake of that, and that is the rise in unintentional drug overdoses, which is represented by the dashed kind of maroon color line. And unfortunately, we saw a correlation that is incredibly closely tied to that increase in distribution of opioids. In about 2011, we became aware that this was a major problem, and that we were seeing these overdose deaths rise in concert with the distribution of opioids. And we did what would seem natural and intuitive. We cut back the distribution of opioids, and we saw that between 2011 and 2017, the distribution dropped dramatically. And this seemed to be a reasonable approach to tackling the opioid crisis. Surely, by decreasing the distribution of opioids, we would see an improvement in some of the adverse events and the overdoses as a result. But as you all may be aware, that is not what happened. What we saw, in fact, was that rather than a decrease in overdose deaths, we saw a marked increase in opioid overdose deaths. The people who were dependent on those opioid prescriptions and no longer had access didn't go away. They didn't stop using. And unfortunately, they transitioned to much more dangerous street drugs on the street, heroin and then fentanyl and carfentanil. And that led us to where we are today with nearly 5,000 overdose deaths in Ohio in 2017. With this information, we can really arm ourselves for a better strategy. Because we didn't anticipate this, we didn't prepare, and we didn't plan a strategy that would improve outcomes and prevent some of these deadly outcomes that we saw. And so what this tells us, I think, as a hospital system, is that if we solely focus our strategy on reducing opioid prescribing, we will see these outcomes continue, and we will see increased overdose deaths, and we will not get the outcome that we are looking for, and we will place our patients at much greater risk. And so what I would like to focus on today is a strategy that is a bit more comprehensive and that takes into consideration all of the facets of the opioid epidemic, from opioid prescribing to treating addiction and to looking upstream. At Metro Health, we have attempted to take this opioid strategy in a bit more comprehensive, sort of ground-up approach. And the mission of our Office of Opioid Safety is essentially to improve opioid safety throughout our system and our community through education, advocacy, and treatment. So really kind of taking a broad look at all of the factors that go into improving safety for our patients. And I have an analogy that I like to use, and it kind of is the shoring up the dam, looking at the dam where it's leaking, and focusing in on creating that sort of emergency stopgap measure that improves safety for our patients immediately. So putting your finger in the dam to stop further leaking, and that leaking would be the fatal overdoses, right? So our number one priority should be to decrease fatal overdoses. Only after we do that can we move upstream and look at the dam and try and reinforce that dam, and that I liken to treating the addiction. So we've stopped people from dying. Next, we need to take those individuals, treat them, make sure that they're safe and that they're stabilized, and then only then can we move upstream and look at prevention measures, and that is represented by our efforts to prevent addiction to opioids in the beginning. So putting our finger in the dam, how do we do that? How do we prevent fatal overdose? The strategy that I would like to focus in on is naloxone. Naloxone is the antidote to opioid overdose and the drug that we use to reverse a fatal overdose. We have adopted a Project Dawn model at our institution, providing naloxone in walk-in sites throughout our community, but we've also incorporated it into our emergency department and into our pharmacy. Our educators essentially, when they provide a Project Dawn kit to an individual, provide education on risk factors for overdose. They teach individuals how to respond to an overdose and how to recognize that overdose. And then an individual is provided with a Project Dawn kit. This intervention, we know, is beneficial, and we know that it improves outcomes based on evidence. One of the articles that I would just like to highlight comes out of the Massachusetts area, one of the largest naloxone distribution programs in the country. And they published an article back in 2013 looking at communities that had access to naloxone versus communities that did not have access to naloxone. And what they found was that those communities that did have access to naloxone, overdose events were reduced. And so, armed with that evidence, we are confident that this is an intervention that can reduce mortality in this population. And we know that it also saves money. The cost of a Project Dawn kit, a naloxone kit, has varied since we started our program. Initially, we were paying about $25 for a naloxone kit. Now it's a little higher. It's about $80 on average, and that's been a pretty stable cost for us. But if you compare that cost to the cost of a fatal drug overdose, nearly $3,000, and the cost of an average inpatient treatment charge for a patient with a drug overdose is about $10,000. And we know that of the individuals who are admitted for inpatient drug overdoses, about 2/3 of those individuals were either uninsured or covered by publicly funded programs. And so, essentially we're comparing a very small cost for this intervention to the very large potential savings for your healthcare system if you are able to prevent these inpatient costs and fatalities. So how can you implement this at your hospital? As I mentioned, we at Metro Health have a comprehensive naloxone distribution program with 5 walk-in sites. You may already have a naloxone distribution program in your community. If not, you may be very near one. The Ohio Department of Health has a website that lists all of the Project Dawn sites that are in your community, and you can check that and just type in your city and see which programs are nearest to you. But if you are interested in providing naloxone directly as you're caring for patients, that can also be done most easily it can be done by writing a prescription for naloxone or Narcan. It is a prescription medication and can be co-prescribed to any patient who is either at risk for overdose or can be co-prescribed to a patient who is at risk because of the opioid prescriptions that they're taking. And we know that there's increased risk for adverse events when that MED goes over 50. And so our recommendation and the recommendation of the CDC is to consider co-prescribing naloxone at MEDs of greater than 50. The state has also made it easier to prescribe to make naloxone available by allowing pharmacies to set up standing order protocols. And at Metro Health, all of our pharmacies have a protocol established with our office to make kits available behind the counter without a prescription. This allows patients to come to any pharmacy and pick up a kit without seeing a doctor and without making an appointment. And then again, lastly, check the Ohio Department of Health website and you may be able to find a Project Dawn site near you. Typically, the Project Dawn walk-in sites offer naloxone free of charge, whereas options number 1 and number 2 will incur a cost for the patient. Not able to advance the slide.
Try clicking once more. There we go.
All right, great. Okay, so moving forward. So now we've already put our finger in the dam. We've done our best to stop fatal overdose. Next, we need to reinforce the dam. We need to treat addiction. We need to identify those folks who we've saved and help them to stabilize them so that they can recover. And how do we do that? We do that with medication-assisted treatment, or MAT, as it is often referred to. MAT is maintenance treatment for opioid use disorder. The 3 FDA-approved medications include methadone, buprenorphine, and naltrexone. Methadone is a full opioid agonist that is used to replace illegal opioids. Buprenorphine is a partial agonist, and it is often coupled with naloxone to prevent diversion and misuse. There is a single agent product as well, the buprenorphine product without naloxone, which is, again, it's a partial agonist. This product is almost solely used for patients who are pregnant because the naloxone can be harmful to a fetus. There are some other situations where it is advantageous to use a buprenorphine product, particularly incarcerated populations where it's just a cheaper product and can be an advantage. But typically for most providers, the buprenorphine product that will be utilized is going to be the buprenorphine naloxone, and that's used for office-based treatment. And the last FDA-approved medication is naltrexone, typically used as a 30-day injectable. You may know it as Vivitrol, and this medication is a full opioid antagonist that can be used to prevent opioid use. So why do we treat opioid use disorder with medications? Well, we know, based on evidence, that it reduces overdose deaths. In a study in Baltimore, after buprenorphine became available, we saw heroin overdose deaths drop by 37%. MAT also increases social functioning, increases retention and treatment, decreases opioid use and criminal activity. It decreases the transmission of infectious diseases like HIV and hepatitis C because patients are no longer injecting drugs into their skin and into their veins. We see decreased incidence of illnesses like endocarditis, as well as skin and soft tissue infections, all of those sort of complications that are seen with injection drug use. And lastly, we know that it improves outcomes for pregnant women and their babies. There's a decrease in the rate of neonatal abstinence syndrome, as well as hospital length of stay for individuals who are treated with medication-assisted treatment. Now, should we treat patients long-term, maintenance, or should we give them a short course, detox them off, and stop treatment? The evidence supports maintenance. And why is that? Because it works. A study done in Sweden showed patients who were maintained on buprenorphine for long-term versus patients who were treated with buprenorphine and weaned off in 6 days. We saw the treatment failure rate for the detox group, the rapid withdrawal group, was 100% compared with a failure rate of 25% for buprenorphine. Protocols that involve rapid detox with no maintenance therapy, whether they are coupled with behavioral treatments or not, are not successful. These patients do very poorly, and evidence strongly supports a long-term maintenance program as opposed to that type of a detox program. Now, despite all of this evidence, medication-assisted treatment is still not widely available. Less than half of substance use disorder programs offer medication-assisted treatment, and only 1/3 of the patients in a program that offers it actually receive it. And so we need to do a better job as healthcare providers making sure that evidence-based treatment is available for our patients. Nearly all states report inadequate access. And there are a number of different ways that we can incorporate medication-assisted treatment into our program. Traditionally, it's offered by opioid treatment programs that are specially designed to have addiction specialists and intense behavioral treatment programs, IOP, partial hospitalization, inpatient detox units. But as this opioid crisis has grown, we understand that there are not enough addiction specialists, and we need to be creative about how we offer MAT. It needs to be offered in a variety of settings so that our patients can access this treatment. Many patients are admitted to the hospital and don't have access to addiction specialists. We need to incorporate MAT as an inpatient consult service, making addiction specialists available to wean patients either off of their medications or onto stabilize them on a buprenorphine program before they're discharged. We can also incorporate MAT into primary care. You don't need to be an addiction specialist to provide MAT. The only requirement is that you obtain a DEA waiver, which is an 8-hour course for physicians and a 24-hour course for PAs and nurse practitioners. And this is a model that can be used to incorporate MAT into routine primary care, either in an individual setting or a shared medical visit and a specialized type of clinic. It can also be incorporated into some of our specialty care programs. For instance, at Metro Health, we have a MAT program incorporated into our OBGYN moms program that couples our pregnant women with opioid use disorder with an MAT provider, as well as some of the support services and behavioral treatments that they need to be successful. MAT can also be offered in the emergency department, and we'll talk a little bit more about that, and for programs that don't have access, particularly rural programs that don't have access to an addiction specialist or any other physicians who have their waiver, telehealth may be an option, and that's an emerging area for growth and increasing access to MAT. So the next area for for increasing access is the emergency department. And the evidence for this was out of Yale, done by Gail D'Onofrio, who looked at initiating buprenorphine in the emergency department. She compared individuals who were started on buprenorphine along with a group that received only a referral and a group that compared the referral group. They received a handout only to another second group that got sort of some motivational interviewing along with an active connection to treatment. So they were basically connected directly to a treatment provider and given some motivation. And then lastly, the third group sort of received all three. They got the negotiation interview, sort of that motivational interview, along with naloxone, the buprenorphine and naloxone. And what they found was that engagement in treatment was greatest in the group that received the induction in the emergency department along with that motivational interview. And so we know that this is a potential area that we can expand MAT and improve our patients' outcomes. It is an area where we touch a lot of patients who have opioid use disorder, particularly for those individuals who don't have a primary care physician and may not have good access to care. They touch our emergency department when they have overdoses, when they have crisis, or when they're seeking treatment. And it is a place that's open 24 hours a day and an ideal setting to incorporate MAT. Other options that we can provide our patients to connect them to treatment include peer support. Ascent ED is a peer support model that provides live peer supporters available 24 hours a day. They also offer a mobile web-based application to provide support. Peer supporters are individuals who are licensed by the state. They provide emotional support. They share lived experience as well as knowledge and information about treatment options and support services in the area. And then lastly, they are able to directly connect patients with the treatment program. In our emergency department, we implemented this program about a year ago and have incorporated the peer supporters available 24 hours a day in our emergency department. They're available immediately to meet with the patients, get them sort of motivated and interested in treatment, and then share that information with them about which treatment programs they may be most successful in. And then if they are interested in the program, we will directly connect them to that treatment program. Oftentimes that's medication-assisted treatment. We'll start the medication-assisted treatment in the emergency department and connect them either with a residential treatment program. If they're in an unstable environment, we may connect them with an inpatient program, but the Ascent peer supporter will take that patient in an Uber directly to the next provider, so providing that warm handoff. Now, lastly, I want to talk about that final piece of our strategy, preventing addiction, looking upstream. We've put our finger in the dam. We've stopped the fatal overdose already. Next, we've shored up the dam by treating our patients with addiction, and now it's time to think about moving upstream and preventing addiction. And we do that in a number of ways at Metro Health. We do that by looking at our data, looking at the patterns of opioid prescribing throughout the system. We do that by reviewing the patterns of individual providers, our peer review program. Our peer review program essentially takes that data that we use for opioid prescribing throughout the system and tries to identify patterns of possibly concerning prescribing, and then work with individual providers who have been identified as having particularly either higher MEDs or a more high-risk population, and allows us to work with that provider and provide interventions to help support them, help provide access to treatment and other resources for their patients, and case management to get those individuals help that they need. And then lastly, we provide education for our providers and for our patients, and we'll talk a little bit more about that in the coming slides, and some informatics initiatives as well. So data, how does this look for our system? We have looked at data on a broad system-wide basis, and also looked at individual departments, making data available for our individual providers so that they can see what their numbers look like, what their numbers look like over time, how they stack up on individual metrics. Are they checking ORs? Are they co-prescribing benzodiazepines with opioids? And what is their average morphine equivalent dose? They're able to see how their performance has improved over time. And they're able to see how they stack up to their peers. So in this scorecard, we see the highest peer at 23.7 opioids per encounter, compared with our lowest peer of 0.3. And this gives a provider a sense of their relationship to their peers. And this can be a very strong motivator to help providers shift their prescribing patterns to be more in line with their peers. Peer review. When we look at the data, again, we often identify patterns that are concerning and that need to be looked a little bit more closely at. Some of the prescribing metrics that we look at include total opioid pills per 100 encounters, so that we have that equalizer, that rate, rather than a pure number. We look at average morphine equivalents, we look at opioids plus benzodiazepines, and we look at ORS compliance. Now, those of you who have tried to look at ORS compliance in the past probably understand that we don't currently have a great way to do that. The system won't allow us to audit our providers' access of the ORS system, but we've done that by creating a smart phrase that our providers have to document in the electronic health record, and then we're able to query that smart phrase so that we can have that ability to at least audit the documentation of the ORS, and our providers understand that that's a requirement. After we identify opioid prescribing trends, we perform a more detailed chart review. So we take a look at charts to try and determine, is the high-level data as concerning as it may look from a distance? We pull 10 charts, we do a detailed review, and look at a number of performance measures to determine, is this really as concerning as the big numbers look, or are there simply a high-risk population that this provider is managing that make it more, their numbers a little kind of jump out at us. If we are we have continued concern for that provider, we'll meet with the provider as a group. We'll share our data. We'll identify areas for them to improve their performance and come up with a performance improvement plan for that provider. Those performance improvement plans often include an educational component, an intense prescribing course. we recommend online modules, and we give them some other tools to help improve their performance. And most recently, we've provided a opioid clinical pharmacist to work with them and help them to come up with plans to wean opioids in a safe setting. And then lastly, we reevaluate the performance. After we review and come up with a plan, we review that performance in typically 3 and 6 months to determine if we're getting the response that we'd like. Next, we educate our providers. There is an ever-changing landscape of legal challenges and changing laws. So we have created Opioid Prescribing Safe Town Hall. This is a educational event that we hold that all of our providers are required to attend. It allows us to update our providers on federal and state laws, identify tools for safe opioid prescribing, teach them how to use those tools, and then how to integrate assessment and management to decrease drug misuse and monitor adherence to the drug regimens. These town halls have been ongoing throughout the past year, and we have nearly 100% compliance with them. These are mandatory sessions, but we also have optional sessions as well. We offer a lunch and learn series for providers and any interested employee to attend. These are areas that we've surveyed our providers and asked, what are some things that you would like to have more information on, more education on. And some of the topics that we've already covered include how to interpret the urine tox screen and the pain management panel. Our providers have struggled with weaning patients off of opioids and asked for additional resources for that, and that has been one of our topics provided to us by our clinical pharmacist, our opioid specialist. Also included sessions on the addiction model and how to manage patients that they may have inherited who are already on chronic opioid therapy. That continues to be a challenge for many of our primary care providers. And so we've done sessions on that as well. We also have created an opioid prescribing provider simulation program. The simulation program is a live actor session in which a provider has a chance to sit down and go through a simulation with an actor and sort of role play a difficult conversation around opioid use. It may be, we have 3 sessions. One is on how to manage a patient who they've inherited. A second is how to address when a patient is on chronic opioids and there is an abnormal or unexpected tox result screen. And then lastly, we have a session on how to address aberrant behaviors that are identified in a patient with opioid use disorder who is on chronic opioids. And these give providers an opportunity to practice that conversation, practice those communication skills that will help them better engage their patient and provide them with the resources that they need. Now, some of the other tools that have been very beneficial to reducing opioid prescribing in our system are some of the things that are built in to our system. Some of the tools that we've built into our electronic health record have gone a long way to reducing opioid prescribing. And really, I think of this as making the safest choice the easiest choice, right? So all of us who have used an electronic health record and use it on a daily basis know that the easiest prescription to write is the default. And we identified all of our default prescribing for our opioids. We pulled all the lists of opioids that are in our Allscripts database and looked at, what are the default quantities? What are the default SIGs? And we found some concerning results. We saw defaults of 60 and 120 tablets for many of these opioids. And so we went through and we culled all of those defaults, and we made a order set and essentially reduced all of those defaults to 3, 5, and 7-day supplies. And we changed the SIG sentence to 1 tablet every 6 hours rather than 1 to 2 tablets every 4 to 6 hours, which is what we had previously. So now we have a very easy default. When I type in the prescription for Percocet, rather than seeing a multitude of potentially very high doses and very high defaults, I can simply choose from a list of a 3, 5, or 7-day supply and automatically get a quantity that is more appropriate and more safe. We've also built in alerts to keep our patients compliant with state law and guidelines as well. But in our emergency and acute care settings, we wanted to ensure that our providers were remaining compliant with the 7-day rule for adults and 5 days for minors, and make sure that they were staying compliant with the 30 MED rule as well. And so if a provider is writing a prescription for more than 1 of 7 days, so if they manually went in and changed our default, they would get an alert. It would tell them that you may be non-compliant with Ohio law if you continue writing this prescription. It's not a hard stop. It'll still allow the provider to write the prescription, but you have to go through this step and override this. And there are, of course, clinical situations where it may be appropriate to go over that MED or go over that duration. And we sat down with our lawyers and came up with some standard language for when that might be appropriate, and made some smart sets just to keep our providers safe, to make sure that they're compliant with the law, and that if they do go over the 30 MED rule, they are documenting it in a way that's going to keep them compliant with the law and keep them safe. And so we've created these standard phrases. And I know you can't read them, but if you're interested in how we wrote them or want to see that, email us and I can provide that verbiage for you. We've also created a similar type of alerts for MEDs over 80 morphine equivalents. So to keep our providers compliant with guidelines, again, this isn't law here, this is state guidelines. If a prescription is written over 80 MED, our providers who are practicing in an ambulatory setting outside of acute care, they will receive a warning saying that you're going over 80 MED, perhaps you should reconsider. Again, not a hard stop. Providers can click through this if they want, but it does give an extra layer of protection and a warning to that provider. And then now lastly, of course, the hardest to read for you, I know, I'm sorry for that. We have created an inline opioid calculator. This shows up as the morphine equivalent dose up here for the provider, or I'm sorry, for the patient. So the total number of opioid pills prescribed in our system are calculated. And if you click on it, then you can see the total calculation here. In our system, we have it programmed so that if you prescribe over the 30 MED limit, that number becomes red and it alerts the provider that that patient is already over 30 MEDs. We've created some additional order sets to make it easier for providers to stay compliant and offer alternative medications. We coupled that with the PEG score so that they can document their function as well as their pain. In our emergency department order set that we created, we also made naloxone available here as an option if an opioid is prescribed. But as you can see, we've included all of our formulary non-opioid medications just to give the providers a easy reminder of some of the other options that are available. And as a result of all of these initiatives, in 18 months of opening our office and implementing these programs, we were able to prescribe 3 million less opioid pills during that time frame. We saw a 62% reduction in prescribed pills for acute pain and a 25% reduction in prescribed pills for chronic pain. Now, at that same time, we increased our number of MAT providers by over 100%. We now have 80 MAT providers in our system, and we have increased our resources for patients who have opioid use disorder as well. All of these outcomes are the result of a comprehensive program, and so it's difficult to identify exactly which of these pieces played the biggest role, but we're very pleased with our success and think that a comprehensive program is really the key to getting these types of outcomes. And so I think now with 15 minutes left, I'd just like to give a brief summary of the topics that we discussed, and then I'd be happy to take any questions. So again, any comprehensive program needs to begin with overdose prevention before moving upstream, increase access to medication-assisted treatment, both in traditional and non-traditional settings, and then finally, an ounce of prevention is worth a pound of cure. If we stop addiction before it starts, we can do that with initiatives and tools to reduce overprescribing and help save our patients and improve opioid safety throughout our community. And so with that, my didactic portion is concluded, and I would be happy to take any questions.
Thank you so much for that, Dr. Papp. Fascinating presentation, tremendous comprehensive work that you are, and this program that you have built at Metro Health. And it's really quite timely given the interest of CMS in this issue, as well as our new governor. So there's a few questions that we have that we'll get to. I do have one question just to start it off. I love this image of plugging the dike, reinforcing the dam, and then moving upstream. And for hospitals that are just beginning this journey, that maybe are smaller, that have fewer resources, that don't have your expertise, do you have a recommendation of where they would start? What's the one thing would be the first thing that they should look at?
So my recommendation is to co-prescribe naloxone with all of your prescriptions greater than 50 MED and to individuals who have an opioid use disorder. This is something that you can do today. It simply requires a change in our practice. It doesn't require any infrastructure build. It doesn't require any new protocol development. It's simply writing a prescription in an ambulatory setting. For patients who may not have the resources to fill a prescription or don't have the financial ability to pay for it, they can be referred to one of the Project Dawn sites in the community. Look up that Ohio Department of Health website and identify a program near them, and those sites will offer the naloxone kits free of charge.
Excellent. More questions around that that have been brought up are, does Metro Health cover the cost of the kit itself, or is there another partner that pays for that currently?
Sure. It does depend on our setting. So we have some grant-funded programs. Ohio Department of Health supports our community-based programs, and those naloxone kits out in the community are free. All of the kits that are supplied in the hospital setting that are not funded by a grant are billed to insurance, and are otherwise included. If we give a kit from the emergency department, we bill in terms of the facilities fee. And so to some degree, we do absorb the cost of that kit. But if it's a prescription, it's billed to insurance.
Okay. And to this end, you've mentioned the Project On multiple times. Here at Ohio Hospitals, a hospital association, we have actually built links to that. We have now a community resource hub that if you go to ohiohospitals.org/hub, and we'll actually type that in. Right, actually, could you put it into the Google and to the Googles, and then people would be able to see this. You can find maps to Project Dawn throughout the state, where to get treatment for those who are addicted, places for drug drop-off, information about classes for data training, data waiver training, and many other things for you and your hospitals. And this is, so it's an easy link of ohiohospitals.org/hub. And you can scroll down just a smidge and you can see those take back locations, Project Dawn, and some other things. And if we could go back to those questions, that would be wonderful.
All right.
And another question is around your ED practitioners and hospitalists. Are they all waived to give Suboxone, or do you have a specified addiction medicine consult service that sees your patients in the ED or in the hospital?
Sure. So we do have about a third of our ED practitioners are waivered, but we also have a nurse practitioner who is dedicated to start Suboxone in the emergency department. So she is a case manager and a nurse practitioner. She sort of consults with patients who are being seen by another provider in the emergency department and assists that provider with writing the prescription, making sure all the appropriate labs are started, making sure that documentation is done appropriately, and making sure that that patient is connected to ongoing treatment. To be honest, it's easiest to start a patient on Suboxone or buprenorphine in the emergency department when Laura, our nurse practitioner, is working. But we do have the resources with our waivered providers. About a third of our providers have their waiver and can write a prescription for Suboxone when they're not there. Unfortunately, providers who do not have their waiver cannot start Suboxone from the emergency department. So it is required to write that prescription. It is not required to administer in the emergency department. So you can give a dose, but you cannot write a prescription.
Thank you for that clarification. Another question then is, after they have started it, you mentioned in your slides a transition through Ascent. Is that a local resource, or is that a resource that is available statewide?
So they are a organization that we have a contract with. It started with a grant, and we have expanded their services and are making them available throughout our system. They have contracted with a couple of different treatment providers in our region as well, and they are also, I believe, looking to expand to the Columbus area as well. And so if anybody is interested in getting more information about peer supporters, I'd be more than happy to connect you with the Ascent CEO. And actually they merged with another group called Thrive. So Thrive or Ascent is the company that offers that. It's not free to patients. I'm sorry, it is free to patients, but it is not a free service.
Sure. Okay, very good. And then there's two questions around the use of naloxone, both being the education that Project Dawn gives is a specified education, and then who in your institution then gives education around the use of naloxone. And then a follow-up question was around injectable naloxone.
Okay, so let's start with education. So it kind of varies based on the setting, right? We try to meet patients where they are. In our walk-in sites, where we are working with patients who are actively using, they often don't have a lot of time to talk with us, and they may not want education, but our kits contain all of the information that they need. Most of those patients have used the medicine before and don't need a lot of verbal education, but we'll spend as much or as little time with individuals in the community setting as possible. In the emergency department, sort of same principle applies. We are willing to give as much or as little education as needed. The state does mandate a education sheet for pharmacists who are distributing this under a standing order protocol, and that education can be delivered with that education sheet. It's very easy to use. It's just a little nasal injector.
Very good. And then I'm sorry, go ahead.
Oh, the injectable naloxone. So again, we utilize injectable naloxone in our syringe exchange program. And so we only offer injectable naloxone, that's the IM naloxone, in settings where people are actively using opioids. And part of the reason for that is because needles can be a trigger for people who are in recovery. And while there's some advantages, particularly because it's very inexpensive, we like to use that if it's possible. We also know it's a little bit more work. You know, you have to be able to navigate the needle, draw up the naloxone, and then inject it, which is a little bit more of a process than the FDA approved nasal spray that's just, you just pull it out of the package and spray it in the nose. So there are advantages and disadvantages. The FDA nasal spray is obviously more expensive. And so we actually use, we use all of them, all forms.
Wonderful. And then the last set of questions were about the peer review process. Yes. And using that versus an internal quality control program at your institution. And I have some theories about it and the others were mentioned of the types of reviewers clearly would have to be within your system if it's peer review. And do you use peer review rather than another program because you can then have it be protected information?
Yes.
And you can do more education and intervention with this.
Correct, right. So our peer review committee is composed of providers throughout the spectrum in our system. So we have pain management providers, we have an addiction provider, we have primary care providers, emergency department providers, all on the committee that review the data, that do chart reviews, and meet with patients. So we try to avoid peers who are within sort of the same department reviewing those peers. But yes, it is a multidisciplinary group so that we get perspectives from all departments. And we do choose the peer review model because oftentimes we identify patterns that are particularly at risk for risk, right? So we want to keep those providers safe and protected under the peer review privilege, and so that is the benefit of doing it through that process.
Wonderful. Well, Dr. Papp, this was wonderful, and we so appreciate you sharing your time and your expertise with us today. Please know that we will be sending out a link to the survey and the evaluation tool to get CEUs, and we'll send this to all attendees. Please mark your calendars for March 19th, our next in the series, with the topic to be determined. And that we will be sending these slides to become 508 compliant, and then we will be posting it to our website here at this hub, which you can see, and I'll say it one more time, is ohiohospitals.org/hub, and to get you to resources for you and your daily work. So thank you all for joining us today for this webcast. This concludes our webcast, and please, all of you, have a great day. Thank you again, Joan.
Thank you.
Very good. You're nice, Joan.
Just controlling